I'm really excited to be here for a couple reasons, because the summit itself, I just love the name. When I heard it, I thought I have to be here, because do no harm. And, as I'm sure you would agree with me, like as someone who works at the intersection of healthcare and the built environment, it's really important to see a fundamental tenet of medicine and healing and healthy living translate to the built environment. So well done for that. And I'm really excited to chair this panel with these exciting individuals, because health and housing are both in this country at an inflection point. In housing, we're trying to build 1.5 million homes. We're trying to do them affordably. We're trying to do them safely, healthily. We're also trying to preserve the environment and preserve our planet. In health, we're trying to deal with an aging society, the demands of an aging society, trying to reduce waiting lists, and at the same time, we're trying to invest in prevention and preventative health. So these are difficult challenges. The challenge is that these two issues, health and housing, are talked about in very separate I don't like the word silos, but in very separate conversations. And the reality is health and housing are kind of the same thing. And they certainly overlap, and I think that's what we're here to talk about today. And what's really exciting about these guys is that they each kind of represent, and I didn't choose them, I think I chose you. But they actually represent three themes that I think are really, really important to inform this discussion and take this out of the silos. The first theme is health is wealth. And that's something that's actually taking place well outside of housing and health. It's actually about the bigger issues around growth, around productivity, around our economy developing, and what is a healthy workforce. You have to be on Mars if you don't know that in recent weeks, Parliament have been debating issues about demands on benefits and the healthiness of our workforce. So health is wealth is something we're going to talk about in this discussion. The second one is the incredible plethora of data, metrics, and new tools for measuring health, understanding the spatial distribution of health outcomes. It's a really exciting area that hasn't really embedded itself into this conversation yet, so we're going to talk a little bit about that. And then we're going to talk a bit about community voices. Preventative health, remember that theme, and affordable housing and the kind of housing we want, the kind of housing that's humanizing, really requires community input and community voices. So these are themes that I think are really important to unify this discussion, to inform this discussion, and for all of us to go away thinking we've got something to contribute. So I want to start on the community theme, and I'm going to look at Dieter here. I recently read an article by Rowan Moore about your Highgate Newtown Community Center. And he started off by saying it epitomizes the humanized principles. And one of the things he talked about is how you had to reconcile the many, many different voices of multiple numbers of stakeholders. And I think the number was 178. Stakeholder groups. So I wanted to ask you, how did you do that, and how did those voices come together and actually inform what has clearly been a very successful humanized development?
It's on? Oh, this way. Just take a little while. Great, thanks. Actually, this is a photo of a different project, but it talks about process, interestingly. This is the project you're referring to, Highgate Newtown Community Centre. 178 groups that we engaged with over the period of the project. I guess we're going with an open mind. You go in without any preconceptions. You go in with a structure and understanding and sharing the kind of scope of influence of those people as well, so that they understand the process and they know how they can input and be involved. And you go deep and wide. So you do a lot of different types of engagement. It's not one size fits all. We very much about awareness building and sort of spreading the message about something happening. So that other photo, interestingly, refers to a process where there are a load of boarded up shutters. So the antithesis of the opposite, if you like, of the Humanised campaign, and they're just boarded up shutters in the shadow of Grenfell in a challenging estate, but opposite very wealthy homes. And part of that process, for the engagement process, the first thing we suggested we do, why don't we paint the shutters? We'll have a painting day. We'll paint the shutters in bright colours, put a new kind of logo across the whole, these 5 shop fronts that was part of this development we were looking at. And we'll demonstrate our intent by doing. It'll be a speaking point. We'll put the website on there as well and start that message about awareness. So there's always a layer of awareness building, if you like. And that happened very much in Highgate as well. But this was over a course of a number of years, the engagement processes. I mean, I guess there's so much one could say about it, having somebody to introduce you so you can build trust. Building trust is very important. That was mentioned earlier that on short-term returns, it's very challenging. So you definitely have to come in with a partner that you can have that instant trust with someone, or build trust at least, and be seen as someone that someone can speak to. There's lots of little techniques that we use as well, sort of almost distraction techniques. You're not talking directly about the questions almost that you want to ask the people that you're engaging with. You're talking about something else, or something else is happening, and that allows you to have more informal conversations. Everything from gathering recipes from the community to understand the demographic rather than filling in a demographic form, through to and trying to understand what the local needs are. So there was it was a long process, and even when we were developing the design and getting onto site, establishing a truly representative group of from the community, we had much more structured sessions with, and as very much you said we did, so we go back with what we've done previously. We introduced things onto the agenda that they had time to talk about their own concerns and issues as well, so it wasn't a one-way directed traffic, if you like. And we also allowed them to take away some of the thinking, speak to their neighbours and relations and come back, so they kind of had homework, so they had to come back afterwards as well, and they fed that back into the process. So it's very much an involved, broad, but also deep.
And of course, that continues to, as they operate the facility and live in the facility and work and transit the facility, that continues. These groups are represented.
They're definitely still evident, and depending on the project, we very much talk at the beginning about the longevity and the stewardship and the long-term role that communities can have. And we had a fantastic input in Brent, actually, in the master plan we were working at for Staples Corner there, where they've now established a residents panel from the community group that we established, and they now have equivalent to like a DRP that has a permanent presence, and they're recognised with sort of vouchers, and so there's sort of a social contract to be there and make sure their voice and is there, and it is valued. I mean, the fundamental principles of the design and the architecture of this project, actually, I'm not sure we're going to get into that, but very much came out of that engagement process as well.
Okay, I'm going to ask Rob now a little question about the health is wealth theme. And, you know, Earls Court, I've been a real fan of that development. I think I was telling your colleague over here earlier. You've really embedded the health and well-being principles and sort of on a mission to make this a very enjoyable, healthy, high quality of life development. And you've embedded that into the master planning and into the planning application. To what extent is this, can you argue that this is not just adding costs, but it's actually generating value? That you actually think embedding health and well-being principles will generate value in the overall development?
Is this working? Hello?
Is it on?
All good? Can you hear me?
No.
No? I've got a green light. Can you hear me now?
Yeah.
There we go. Yeah, hi everyone. Rob Heasman. Thanks for having me, Thomas and Matt. So I think from my perspective, how do you embed it? How is health equal wealth? I mean, I think we started Earls Court at the start of 2021. So we were in the pandemic, which wasn't the easiest time to A, learn about a place, B, recruit a team, and C, to kind of get going. But actually I was wrong because everyone was on thumbnails. I had immense access to people who wouldn't usually come to your office or to a public meeting. And so we were able to open, I think, a really broad conversation because people weren't doing much. I think that you have to start with baseline data. I mean, it sounds boring, but I was listening to Hilary speak before, and the word curiosity really strikes a chord. You have to, particularly with something of the scale of Earls Court, it is a project. The one question I get asked the whole time is, well, there's two questions. How long is it going to take, and are you going to be there at the end? The second question, I never quite understand why I get asked that, but you have to understand the issues that are prevalent on the sites you're working on, because if you don't, what you come forward with is going to lack substance. So we were very acutely aware that obviously there'd been previous plans for the site, and our plans needed to be different for a few reasons. We also did a lot of research around the demographics of the area, We knew where the pockets of deprivation were, pockets of affluence. We knew that there was a really big deficiency in public open space and access to high quality open space. We know there are big issues in terms of air quality and noise pollution. That's just a few of them. So that was a starting point. Then that enabled us to really have a conversation with local community groups, of which there's a few. And of course, they know a hell of a lot more than you know as the developer because you're new. So they are an incredible source of information and inspiration as well to help you start formulating your briefs and also starting to talk about a vision for a place. To cut a long story short, over the first 12 months, so this was by November 2021, we felt confident enough to come forward with a vision, which was to bring the wonder back to Earls Court. And that was really a reference to former glories of what this site is known for and loved and cherished throughout the world in terms of a place where happy memories were made. And so for us as a team, that gave us the confidence to say, well, what did wonder mean to you, to a number of different groups, because as we all know, different groups have different opinions. And for us as a team, there were probably people in the team that were a little bit, are you sure? But at the same time, I think ambition is also very important to convey right at the outset. And for us, that's really helped us. And of course, visions evolve as your plans do as well. But the conversation was always there, the curiosity to learn about that as well. So I think that was a good starting point for us. And then the question about health is wealth. Well, I'm sure at some point today someone else has said it, but how can you not think about health, particularly at a time where there's the first global pandemic going on in 100 years, when what was actually in our thoughts was, are we ever going to get out of this? Are we going to go back to the office? How are we going to socialise? Everything was kind of up in the air. So it wasn't really a very difficult conversation for us to approach at the start. But of course, there are conversations with investors around, how do you make the economics of development work, which is obviously a much bigger conversation. But I think embedding it at the start, creating that curiosity, and then as a business, having a culture that's going to allow people to continue to explore that is very important.
I mean, you've also kind of broadened the definition of health into creative health by bringing the music element into it. Is that fair to say? This goes back to does anybody in this room remember Earls Court as a music venue? I'm really curious. Yeah? Who did you see there? I saw Bruce Springsteen, and yeah. Okay. But aren't you actually doing work around creative health, like bringing back the elements of music and how that's going to contribute to the life of the development?
Yeah, look, as part of our visioning exercise, someone who was in the team, an external company called Mindfolio, we started to examine what are the levelers, in terms of, culture, music, sport, food. Doesn't matter what's in your wallet, it's accessible. And, Earls Court, had Olympics, it had big concerts. Most people have got a really, fantastic memory of being there. And we wanted to kind of, absolutely hold on to that.
And when you submitted the application, was this, did you have measurements of this? Is that something you were able to access data to actually show what the benefits would be?
Yeah, well, Rebecca Ponchek, who's in my team, has done an incredible amount of work. At the start, we were very determined and also very consciously aware, and this isn't just this project, it's actually other projects I've worked on. Typically these big regeneration projects take, 2, 3, 4 goes to get going. It's a shame, really, but it's the truth. And so we're always mindful of what had happened before and how would people kind of engage with what we're doing. And so we purposely set up as a business, a local business. So we're based right next to site. I didn't really quite realise this when I took the job, but we inherited an empty site, but also about 65 properties as well. So we had the space to do some things and experiment. And Rebecca basically set up a process whereby we start to measure right from the outset the social impact and economic value that our interventions and our outreach, our meanwhile uses can have as we're formulating our plans, which actually are quite cost effective because we had the buildings. Yes, there was some improvements that we had to make, some infrastructure that we needed to put on site, but we just basically partnered with great operators like, the Lost Estate, Underbelly, Live Nation, and now the Greatest Show is on site as well, and left, the operators to do it. But we've started to kind of measure annually what that impact has been. And I think the other thing is, rather than just statistics, you learn so much on the way as well, which just can't be underestimated.
Yeah, so you mentioned about getting a good understanding of the areas of deprivation and the sort of variation in your area, because you straddle this project straddles 2 local authorities, so that had its own challenges, I think. So I want to get on to the data question, and Johnny, this is really directed at you because we now know, even in the last 10 years, even in the last 5 years since the pandemic, that health outcomes across the country and within London vary hugely. And by that, I don't mean like how often people get sick. I mean how long people live. Life expectancy varies across the 32 London boroughs. It's astonishing that, I think there's an analogy about the district line, from east to west and just the variation in life expectancy, which says very loudly and clearly that not everybody has the same health outcome. And we have more and more data now that actually shows this. They show the social determinants of health, the spatial distribution of that. Thanks to the work of Sir Michael Marmot, who I think some of you in this room know, who I've been working with in the last year, we know exactly how that's constituted and what contributes to that. And then final point, before I get too excited about all this, is there's so much data out there, there's so much data that people don't even know about. Biobank. Everybody here know about Biobank? Because if you don't, you should. And then there's this other project called Our Future Health, and if people in the room don't know what that is, you should look it up and sign up for it. How do we use this data about health to inform how the built environment is impacting our health and to actually make healthier places?
So first of all, is this working? Sounds like it is. Yeah. Okay. So thank you very much. It's not an easy question to answer, so I'll do my best to try and approach it in a way that's sensible. So I began my thinking about this in the context of do no harm, and it sort of brought me to this idea that changes to spaces and to development are hoping to make things better for people, but it's about recognizing in part that the changes that happen are not necessarily impacting people equally across society, or that are exposed to that change. And so if you think back to the census in 2021 during the pandemic, about half of people who responded said that their health was not very good. So half of the population had less than perfect health. If you go to look at pensioners, in that age group, about half of the population said that their health was not good. So it's sometimes sort of idealistic or optimistic to think that the people that are interacting with these spaces are healthy, vibrant people enjoying the spaces. Often these are people who've got health conditions where their health is less than perfect. And that's sort of, I guess, an early example of how data can potentially help us, because these census data are available at almost microdata level. We're talking sort of LSOA, lower super output area levels, so 33,000 separate units across the country you can use to understand the subjective health of people as of the last census. But in terms of understanding that data space, there is a wealth of information that we can use. We can use information about socioeconomic deprivation. We can use information about things that are related to socioeconomic deprivation, things like community cohesion. There's the Oxford Consultants for Social Inclusion have done a whole separate index that sits alongside the index of multiple deprivation to try and address some of what its perceived deficiencies when it comes to thinking about how people coexist in a space. Beyond that, there's a wealth of data that is collected by virtue of your interactions with the health system. So it's primary care data, it's secondary care data. Every time you go to the GP, it's recorded. And in some cases, it's accessible for purposes of research. It's not accessible for purposes like the ones that we're describing today, because the infrastructure doesn't exist, and the means by which to get that to the point at which you can understand the health implications of an intervention isn't there at all.
But Johnny, do you think it's just because the data isn't available, or it's because the people who own it or the people who use it just don't talk to each other?
So firstly, it's precious data. I'd go as far as to say it's data that is not collected for the purpose of its use in this context. It's collected so that you can receive healthcare. So there are additional challenges there in terms of what we think about how our healthcare data can be used. I think in terms of the context of redevelopment, there's something about baking in an evaluation mindset into development and understanding not just the consultation and the work that goes on in the pre-development phase, but also thinking after the development happens following up so we can learn what worked, what didn't. Some of that is qualitative, some of that is talking to people and continuing to talk to them. But some of it is also using the data that we have in a more sensible way after things happen to understand how things change.
So don't you think, though, that because A, 3 principles here, A, everybody cares about their health, right? We all agree, everybody cares about their health, okay? Not everybody cares about schools, not everybody cares about roads or cars or bicycles, but they all care about their health. 2, all this data is available. 3, we want to have better community engagement. Isn't there like an obvious opportunity staring us in the face about having like these local health communities to sort of set up, and how we use this data to then inform the people who are developing our built environment? Is that such a wild idea?
So I think it's very good to have more information at the point at which you're considering a development. I think there's a wealth of information that could be better used. And I think that a lot of that information is publicly available. Thinking about the census data, it's extremely rich. Thinking about the data that will follow in the years to come, it will only become richer. That's the direction that things are going in. I think what I would be more concerned about is using those similar data after a development to demonstrate its benefit, because the causal chain between a development or a change to a space and the experience of people who interact with that space in a range of ways is really meandering. And it's sort of that the causal purity of that relationship is polluted by lots and lots of other things that in my day job of trying to work out whether NHS policy change makes a difference to something is really complicated. It's a long way away from giving a patient a tablet and seeing what happens. And so I think that side of things is extremely challenging. And I think a more qualitative mode of data collection, even though it's not necessarily the use of these fancy data sets that we have now, is far richer and far more specific to the context. But you need to do it before and after to be able to compare.
Okay, and I mean, I guess the final question, that's the most obvious sort of visual manifestation of buildings and health, is when you have Section 106 funds, the developers' contributions actually used for things like GP surgeries or other things. Do you think that's a good thing, or do you think that it should be something more organic, that we should be using this data and embed preventative health more into the design itself?
Well, I think anything that allows for better healthcare infrastructure to be incorporated into developments
You would say that.
is a good thing. And I think it is a problem. And where data can help is as part of that rebuttal to attempts to not incorporate infrastructure as part of those developments. I think if you can say, well, no, you're saying we don't need a GP surgery, but I think we do. And that's not just using the data we have now, but it's making inferences and future projections about what something might look like in however many years' time. Any projection can be contested, and they often are. And sometimes in these conversations, you're presented with a favourable projection that means you don't need to invest in that infrastructure. I think it should be contested.
Any other panelists have something to contribute to that point?
Yeah, I just one thing. When I was working on Elephant, I got introduced to
Elephant
a guy.
and Castle.
Sorry, Elephant Castle, not an elephant. I got introduced to an incredible person called Professor Kevin Fenton, who at the time was, Southwark had seconded him, I think, for 3 years as their head of social regeneration. And I was doing a piece of work when I was at Lendlease around, we just won a load of new projects, and it was an innovation kind of exercise to see what could add value across the portfolio. And through speaking to Kevin, it became clear that health could be an issue that we could explore a bit further. To cut a long story short, he said to me, in my role as head of Public Health England, or was it Public Health London at the time? He's done both roles, but anyway, an important role. He said, I'm responsible for the public health of, millions of people. Local authorities are responsible in London for about 250,000 people, the health of them. So, but you as developers, you've got the ability to make positive impacts on millions of people that go through, whether they live or work or just pass through your sites. He said, I'm administering, I'll never forget, he said it, I'm administering a cure, but you're the preventative treatment. And to cut a long story short, that led to us doing a piece of research locally in Southwark around what were the biggest health issues. And we just basically got a group of students to interview people on the streets and in some of our buildings. And we didn't know what was going to come back from it. But basically, the biggest issue, far and above, that people were saying was social isolation and loneliness. which at the time the British Red Cross had done some work on, saying it is a pandemic and it's affecting 9 million people in this country. This was before the pandemic, so it was 2017. We didn't really know what to do with this information, so we basically partnered with a not-for-profit organisation called Collectively, and they hosted a innovation hack for a week, which, Matt, you remember well, which was just exploring the topic, and it had a really diverse group of people, about 150 people. And the commitment was then, well, what are the findings that come from that, and how can that get applied to the built environment? And it was interesting because there are lots of things, lots of interventions were potentially low cost, but if they're actually embedded at the outset up front, then they can have a measurable kind of impact. So little things like how do you introduce interaction within tall buildings and trying to foster community, a big subject that lots of people in the room probably part of. Equally with retail as well, how do you create an environment whereby it doesn't just happen organically, it's actually encouraged. So that people feel more welcome in a place, and obviously the shopkeeper can benefit from higher income. So it was.
Dieter, have you been doing any of this kind of embedding in the projects up in Highgate?
Yeah, well, we have, and I was going to say whilst data, you can argue two things. I think data could be really helpful for inputting things into projects and convincing people to do things. But at the same time, you also design for flexibility, and there's some well-being principles that you can certainly put into most schemes. I mean, Highgate actually, I mentioned the courtyard came out as an opportunity that came out of the engagement, this central space at the heart of the scheme, which was a cul-de-sac where two neighbourhoods were distinct previously. The idea of putting this courtyard at the centre came out of that. All the entrances and things come off that space. So it is absolutely a space about social cohesion and bringing people together. And those sort of principles can absolutely be embedded in all schemes. It's interesting, we had a project once that was published in the Architects Journal that was referred to as Building Could Make You Live Longer. And it was a retirement living scheme. And we did some innovation in the Winter Garden, which is like an enclosed balcony type space where they were connected together. And it was kind of like a checkerboard in elevation, if you like. So hit and miss balconies, double height spaces. And what it meant was that you had sort of 6 times the number of your neighbours and you met them much more frequently. And just introducing chance meetings and interactions and spaces where people naturally pass each other is such a simple thing to do. And it's a bit like putting the staircase on show so people use the staircase. These are really simple things that can completely change a place, not just the well-being of the individual physically, but absolutely about the social cohesion, because then there's independence and interdependence, which means you're relying on your neighbours and other people who live with you.
And I think some of these can't really be planned. I mean, it's not quite serendipity, but I mean, I know Johnny's nodding his head, but I mean, I think we all know that a lot of GPs, it was actually a survey of this last year, that the majority of GPs in England said that the majority of their patients do not talk to them about clinical challenges in their life. Their quality of life is impacted more by housing and benefits than it is by any kind of illness. So that's an important takeaway, I think, from this. And I think the other thing is, we have data and we have, opportunities like Kevin, and I think, Kevin Fenton, if you don't know him, I think he actually had a title. His job title was Health and Placemaking, which was very visionary at the time. We should all have a director of health and placemaking. But often these people are just physically separate, so they don't have the kinds of conversations and the opportunities for serendipity to actually make these changes. I mean, how did you meet Kevin?
Purely because, sorry. Hello? Yeah, purely because I was introduced to him because I was working obviously closely with Southwark, and he was seconded there, and he gave us some of his time, and completely, to be quite frank, changed the way we were thinking about things. At the time we'd been through the master planning process, but I think we were just doing the normal in terms of thinking about spaces, desire lines, good design principles. But we weren't thinking the way he was, which was basically value for money and public health. It was a completely different mindset.
I want to thank our panelists. It's been a really exciting conversation.